Okay, guys, settle down. Today we are going to talk about the two important cranial nerves, the fifth cranial nerve, which is the trigeminal, and the seventh cranial nerve, which is the facial. We have been doing this in the neuroscience block, but in the neuroscience block we had the major emphasis on the central nuclei of these nerves. So what we are going to do now in the head and neck is basically the peripheral distribution of these nerves and how they reach to their target tissues and the branches of these nerves. This is what it is. And because most of the sensory and the motor supply of the head and neck, especially the face and this area, is supplied by trigeminal and facial. Trigeminal is mainly sensory and facial is mainly motor. Except that you should know that the muscles of mastication are supplied by trigeminal, which is the mandibular division of trigeminal, and the muscles of facial expression are basically supplied by the facial nerve. There is also embryologically, which you should know, that the first arch, which is important in the making of the muscles of mastication, the nerve of the first arch is trigeminal. That's why trigeminal supplies the muscles of mastication. And because the muscles of facial expression, they arise from the second arch, and that's why the nerve of the second arch is the facial nerve, which supplies the muscles of facial expression. And then the muscles of pharynx and larynx, they are coming from the third arch, and that's why the nerve for the third arch is glossopharyngeal and vagus, which are basically supplying the muscles of pharynx and larynx. So this is also embryologically there, so that you have the concept why, even if you don't remember exactly which muscle is supplied by which nerve, you can just make out that from which arch this nerve is supplying, and that's basis on that which muscle is going to be supplied by which nerve. Okay, so trigeminal is a mixed nerve. We know that it is sensory and motor. It has three divisions. So trigeminal, if you see from the brainstem, it comes out with two rootlets, a motor rootlet and a sensory rootlet at the upper part of the pons. And then it is going to, exit out because it is in the posterior cranial fossa, so it is going to exit out and will reach the middle cranial fossa, where there is the Assyrian or trigeminal ganglion. Now, the sensory rootlet will go into the trigeminal ganglion. The motor rootlet will pass just below the trigeminal ganglion, and then will pass through the foramen ovale when the mandibular nerve is going to be formed. So trigeminal ganglion, which is mainly the sensory part of it, would have three branches: the ophthalmic, which is called V1, the maxillary, which is called V2, and the mandibular, which is called V3. Now, ophthalmic and maxillary will come out from the trigeminal, and they would enter into the lateral wall of cavernous sinus. So in the lateral wall of cavernous sinus, you would have ophthalmic in front, behind is the maxillary, and then you have the oculomotor, which is there in the lateral wall of the cavernous sinus. So these are the nerves which are basically present in the lateral wall of cavernous sinus. Now, ophthalmic is going to come out from the lateral wall of the cavernous sinus, and it would enter into the superior orbital fissure, and it would divide into its three terminal branches, which will enter into the orbit. And as it is entering into the orbit, it is going to supply the sensory supply to the eye, to the upper eyelid, to the forehead, all the way up to the scalp. sensory supply to the lacrimal gland and also to the nose, some part of the nose. This is basically the division which is called ophthalmic. Ophthalmic is purely sensory nerve. The maxillary, which is also in the lateral wall of the cavernous sinus, when it exits the lateral wall of cavernous sinus, it finds another foramen in the middle cranial fossa, which is called foramen rotunda. So it passes into the foramen rotunda and then enters into the pterygopalatine fossa, which is just behind the orbit and medial to the infratemporal fossa. And if you go medial to the pterygopalatine fossa, you are entering into the nose. So pterygopalatine fossa is a small space which is behind the orbit. Laterally is the infratemporal fossa, medially is the nose, inferiorly is the palate, and posteriorly is the phalanx. This is how pterygopalatine fossa is there. So the maxillary is entering into the pterygopalatine fossa through the foramen rotunda, and then it would find the orbit in front. So it will continue in the floor of the orbit, and as through the inferior orbital fissure, it would enter into the orbit, run on the floor of the orbit. So as it is running into the floor of the orbit, its name changes and it becomes the infraorbital nerve. And then it is going to exit out from a foramen here in the skull, which is called infraorbital foramen. So it's like a straight nerve. It's just passing from foramen rotunda into pterygopalatine fossa, into the orbit through the infraorbital fissure and becomes the infraorbital nerve, and then running on the floor of the orbit to come out as the infraorbital nerve. Okay? The third one is the mandibular division, which does not enter into the lateral wall of cavernous sinus. So it will come out from the trigeminal ganglion and it would join, the motor rootlet would join it and it would exit out through the foramen ovale into the infratemporal fossa, where it is going to supply different structures which we are going to see. So there are three nerves, V1 going into the orbit through the superior orbital fissure and then dividing into its three terminal branches, which are all sensory. The maxillary passing through foramen rotunda into pterygopalatine fossa, then entering through the infraorbital fissure to the orbit, running on the floor of the orbit as infraorbital nerve, exits out on the face as infraorbital nerve. Mandibular joining its motor rootlet, it comes out from trigeminal ganglion, joins its motor rootlet, exits out from foramen ovale into the infratemporal fossa, where it is going to give its branches. Okay, all three of them. So major area of supply of ophthalmic or V1 is eye and forehead. Major area of supply of maxillary is cheek and upper teeth and upper lip. Mandibular division is going to supply the mandible, the lower lip, the lower teeth, and all the muscles of mastication, because it is motor also, it's a sensory plus motor nerve. It also supplies tensor tympani and tensor villi, palatini muscles besides, and some of the accessory muscles of mastications are also supplied by the mandibular division. Now, you also need to know that the fifth cranial nerve also acts as a conduit for taking the parasympathetic supply of the third nerve, the seventh nerve, and the ninth nerve to their target tissue. Now, the third nerve, if you remember, the parasympathetic ganglion, which is associated with the third nerve, is ciliary ganglion. So, ciliary ganglion is attached with the branch of ophthalmic, which is called nasociliary, and that supplies, the parasympathetic supply to smooth muscles in the eye, the ciliary muscle, and the sphincter pupillary muscle. The auriculotemporal nerve, which is basically supplying the parotid, has the lodging of the otic ganglion, and the lingual nerve, which is the branch of mandibular, lodges another ganglion which is called submandibular ganglion, which is basically functionally the part of the facial. So these nerves are also acting as the conduit for the parasympathetic supply of the third, the seventh, and the ninth cranial nerves. Okay, so this is the area of distribution of the V1. So you can see the upper eyelid, the forehead up to the vertex, and also the central part of your nose. This area is supplied by the V1. This area, lateral side of your nose, the cheek and the zygomatic arch, this is the area of supply of maxillary. And then the lower lip, the chin, and the side of your temple is supplied by the mandibular division. Why do you need to know about this? Because when you are doing the cranial nerve examination, they will ask you to test trigeminal. So how would you test trigeminal? You have a cotton wig, you touch at different places and see, or you do the pinprick at different places. Similarly, because eye is also supplied by trigeminal, so you can do the corneal reflex. You take a cotton wig and you touch the cornea, your eyes will close. So you are checking both the fifth and the seventh cranial nerve, because closing of the eye is the action of the seventh. So this is important because you need to do a cranial nerve examination and you need to know the distribution. Plus, there is a condition which is called herpes zoster, and sometimes, you know, it is going to, the virus is going to grow within the distribution of a trigeminal nerve. So you have all the skin pimples in that distribution, and it's very painful. So you would, herpes zoster happens within the distribution of the nerve. Then you can also have trigeminal neuralgias, which are also very painful conditions, and they would be within the distribution of the division of the trigeminal. Yes?
It would be in the distribution of
one of the branches of the nerves. So here you are seeing the, you can see that from pons the trigeminal nerve is arising, and this is the trigeminal ganglion in the middle cranial fossa. You see the three nerves arising, V1 going into the orbit, V2 going into the foramen rotundum, and V3 is going into the foramen ovale. Now the four different parasympathetic ganglion. One is attached to the branch of the ophthalmic, which is the ciliary ganglion. It's in the orbit. In the pterygopalatine ganglion, you have the maxillary nerve, which is attaching the pterygopalatine ganglion. Then in the infratemporal fossa, you have the otic ganglion attached to auriculotemporal nerve. And in the submandibular fossa, you have the submandibular ganglion attached to the lingual nerve. So these are the four parasympathetic ganglion. All are attached to branches of trigeminal, but all are functionally not related to trigeminal. Pterygopalatine and submandibular are related to facial, otic is related to the seventh, and ciliary is basically related to oculomotor nerve. Now we are going to go one by one. So we will start with ophthalmic. So we are going to cover four nerves today: ophthalmic, maxillary, mandibular we did last time a little bit, and then we are going to do the facial. So ophthalmic division is a pure sensory nerve. It is going to supply the frontal, sphenoidal, ethmoidal, paranasal air sinuses. So that's why if you have a frontal headache, it can be because of frontal sinusitis, and frontal sinusitis pain is in the forehead because you have a branch of the facial base, branch of the ophthalmic division of trigeminal, which is supplying there. General sensations to nasal cavity, cornea, and your conjunctiva are basically supplied by ophthalmic division. Upper eyelid, the tip of the nose, the central part, the forehead, and the scalp up to the vertex is supplied by the ophthalmic division of trigeminal. It lodges a ganglion which is called the ciliary ganglion, which is functionally part of the third cranial nerve. Now you can see it here, it's a simple plan. So it arises from the trigeminal ganglion, enters into the lateral wall of the cavernous sinus, then enters through the superior orbital fissure into the orbit. As it enters into the orbit, it divides into its three terminal branches. The three branches which it gives are frontal nerve, lacrimal nerve, and nasociliary. So these are the three nerves which the ophthalmic division of trigeminal will give: lacrimal, frontal, nasociliary. Now lacrimal is easy. It is basically going on the lateral wall to the lacrimal gland and then exits out and supplies the lateral part of your upper eyelid. Okay. The frontal nerve will run on the roof of the orbit. It will reach the margin of the orbit where it is going to divide into supraorbital and no, not intraorbital, supraorbital and supratrochlear, supraorbital and supratrochlear nerves, and these are the nerves which are going to supply the upper eyelid, the forehead, and also the scalp, and also the frontal air sinus. So supraorbital, supratrochlear nerves are supplying the upper eyelid, the forehead, and the scalp. Now this one, which is the medial one, is the longest branch, and it gives several other branches, the nasociliary, which will pass below the optic nerve and move towards the medial wall. It is going to give ganglionic branches to the pterygopalatine ganglion, and it is going to give long ciliary branches which will enter into the eyeball, supply the conjunctiva and the cornea, and this is a sensory nerve, which are long ciliary branches of the nasociliary, which are these. They would enter into the eyeball, supply the eyeball, supply the cornea, the conjunctiva. This is the sensory supply to the eyeball. So when you have eye pain, this is because of long ciliary nerve, which is basically a branch of nasociliary. Now, this nerve also gives posterior ethmoidal nerve, which will enter into the posterior ethmoidal canal on the medial part of the orbit to supply the ethmoidal air sinuses and the sphenoidal air sinus. And then it is going to give anterior ethmoidal nerve, which will enter into the anterior cranial fossa. And then if you see the cribriform plate, it will dip down from the cribriform plate into the nose. So it will supply the nasal branches to the nose. And then where your nasal bone is joining the cartilage, it will come out, the anterior ethmoidal nerve as external nasal nerve and will supply the tip of the nose, this central area of your nose. So again, you have three nerves: lacrimal going laterally, supplying the lacrimal gland and the upper eyelid. You have the frontal nerve running on the roof, at the margin of the orbit, dividing into supraorbital and supratrochlear. These nerves are going to supply the forehead, the frontal air sinus, the scalp up to the. Then you have nasociliary, which has ganglionic branches to the ciliary ganglion, long ciliary branches to the eyeball itself, posterior ethmoidal nerve, which is going to enter into the ethmoidal air sinus, and it is going to also supply the sphenoidal air sinus. The anterior ethmoidal nerve, which will enter through the anterior ethmoidal canal into the anterior cranial fossa, dip down from the side of the cribriform plate into the nose, supply the anterior part of the nose, and then exits out at the junction of the nasal bone and the cartilage to come out and supply the tip of the nose, the central part. And then finally, this nerve, which is going to go down and exit out below the trochlear, which is called the infratrochlear nerve, which supply the medial part of your eyesight.
Doctor, the anterior ethmoidal nerve, you said it runs down the cribriform plate. Does it run alongside the olfactory nerve?
No, no. Olfactory nerve is coming through the olfactory holes. This is on the side of the cribriform plate, there is a hole through which it will go down.
It's a dedicated place for it.
Yeah. It has an anterior ethmoidal foramen through which it is going to go down. Yes.
What's the LPS?
Sorry?
Abbreviation LPS.
Levator palpebral superioris muscle. Okay.
That's from the ciliary gland.
Sorry?
That has a part from the ciliary gland.
No. It is not going to be supplied. It is going to be supplied by oculomotor nerve. All the muscles of the eye which move the eye are all supplied by oculomotor. The third cranial nerve. Levator palpebral superioris is a part of the extraocular muscles. Okay, so this is the superior orbital fissure through which you can see that this is the superior orbital fissure through which the ophthalmic division of trigeminal is entering, and as it is going to enter, it is going to give this frontal nerve, which you can see, it is on the roof. You see this nerve? This is the frontal nerve. This is dividing into supraorbital and supratrochlear nerves. Then you can see the lacrimal nerve laterally. You can see the nasociliary nerve going towards the medial wall. Below, this is the optic nerve. It is passing below the optic nerve to go to the medial side of the orbit. Again, you can see from the branches of the nasociliary, the anterior ethmoidal and posterior ethmoidal would be here. You can see this is the long ciliary going into the eye from the nasociliary. You can see the ethmoidal nerves, anterior and posterior ethmoidal nerves from the nasociliary here. This is the area of supply. So this is supraorbital, supratrochlear. This is infratrochlear, which is a branch of nasociliary. They are all going to supply this area. And then the ethmoidal nerve, which has gone down into the nose, is going to supply this anterior area of the nose before it exits out here and supply the tip of the nose. Yes.
Can you show the lacrimal
Yeah. You see, this is the lateral wall. This is the lacrimal nerve.
What view is that?
Yeah. So this is the eyeball. This is the medial side. This is the lateral side.
Okay.
Okay.
Doctor, the first image, can you tell what's the nerve?
This is the frontal nerve in the roof. We just have removed the roof of the orbit. You see the eyeball. Between the eyeball and the roof are these nerves. These are the frontal nerves. Branches of the frontal nerves also you are seeing there. So this is basically, if you see the dissections of the one which you have in the lab also, I think there is a videos of these dissections. These pictures are from the same dissections. Okay. Now we are coming to the second nerve, which is the maxillary nerve. Maxillary nerve is a pure sensory nerve. It is going to supply the maxillary air sinus. So when you have maxillary sinusitis, and because maxillary nerve also supplies the upper teeth, so when you have maxillary sinusitis, you have a referred pain to the upper teeth. So that is an indication that your maxilla are full. It supplies general sensations to majority of the nose. So majority of the sensory supply to the nose is by the maxillary nerve. It has coming distribution from the ethmoidal nerve, which is the branch of ophthalmic, but majority of the nose, the sensory supply. We are not talking about sensation, the smell sensation. Sensory sensation is coming from the maxillary. the lower eyelid, the cheek, the upper lip, and all upper teeth and gum. They are all supplied by maxillary nerve. Maxillary nerve although enters the orbit, but it does not supply the eye. You know, it only supplies the lower lid. It doesn't supply the eyeball itself. So when you have eyeball pain, it is mainly because of the yeah. So, but it takes the parasympathetic supply to the lacrimal gland. So tearing has something to do for producing tearing, which is functionally part of the facial, but those branches which take the tear parasympathetic supply to the lacrimal gland are going to go within the branches of the maxillary nerve. So although it is purely sensory, but the parasympathetic supply to the lacrimal gland would travel within the branches of maxillary to reach the lacrimal gland. There is no direct branch of facial reaching directly to the lacrimal gland. So whatever the facial is giving, it has to reach the pterygopalatine ganglion and then travel within the branches of maxillary to reach the lacrimal gland. Okay?
Doctor,
Yes.
plus ophthalmic also gives off lacrimal nerve, right? So
Sorry? Yeah, but that's sensory. That's sensory. It's mainly the branches of the maxillary which will take the parasympathetic supply. Although those branches will also join lacrimal before they enter the lacrimal gland, but majority of the parasympathetic supply is going to go with the branches of maxillary, and even pterygopalatine ganglion itself is basically held, it's basically held with the two of the ganglionic branches of maxillary. Okay. So let's move forward. So this is the nerve which we know that it arises from the trigeminal ganglion, passes through the foramen rotundum, enters into this space which is called the pterygopalatine fossa, then passes through the inferior orbital fissure, runs on the floor of the orbit as the infraorbital nerve, and then exits out through the infraorbital foramen as infraorbital nerve. Clear? Straight line. Looks quite jagged, but it's like a straight line. It's going from rotundum, pterygopalatine fossa, finds the infraorbital fissure, enters into the floor of the orbit, goes out and exits out through the infraorbital foramen. Now, what is happening here is that in the pterygopalatine fossa, it is going to give branches. Then it is going to give branches as it enters into the orbit. Okay. And then when it is running on the floor of the orbit, it is going to give branches. And when it is going to exit out from the infraorbital foramen, it is going to give branches. So first set of branches are going to be within the pterygopalatine fossa. And you need to remember that pterygopalatine fossa has several communications. It has a communication with the nose, it has communication with the palate, which is hard palate and soft palate. It is communicating with the orbit, and it is communicating behind to the pharynx. Okay? So these are the communications of the pterygopalatine fossa. If you remember this, branches are easy. So in the pterygopalatine fossa, there is a ganglion, which is pterygopalatine ganglion. So it gives ganglionic branches to pterygopalatine ganglion. Through medially there is nose, so it gives nasal branches which are posterior medial and posterior lateral nasal branches to the nose. Then it also gives a branch which is called nasopalatine nerve, which passes through sphenopalatine, but it is going to supply the septum of the nose. So posterior medial and posterior lateral nasal branches supply posterior part of the nose. Nasopalatine branch is going to supply the septum of the nose inside, and then it is going to pass through the incisive foramen into the palate. palatine and lesser palatine nerves going to hard palate and soft palate, and then through the pterygomaxillary fissure it gives a branch into posterior surface of maxilla, which is called posterior superior alveolar nerve. This is going to supply the upper molar teeth. So posterior superior alveolar nerve, which will go into the infratemporal fossa, pierce the posterior surface of maxilla and supply the upper molar teeth. So how many branches? We have talked about nasal branches, posterior superior and posterior medial nasal branches, nasopalatine branch. We have talked about the greater palatine, the lesser palatine, ganglionic branches, and posterior superior alveolar nerve. Now, before it enters into the orbit as the infraorbital nerve, it gives a zygomatic branch, which will also enter into the orbit. Okay, so infraorbital is running on the groove, and a zygomatic branch which is going to go towards the lateral wall of the orbit. Now this zygomatic branch divides into two branches, zygomaticotemporal, zygomaticofacial, and there are two foramens here, zygomaticotemporal and facial, through which they are going to come out and supply this your prominence of the cheek. The zygomatic temporal also connects to the lacrimal nerve, and this is the nerve which is going to bring the parasympathetic supply from the pterygopalatine ganglion, links it to the lacrimal to reach the lacrimal gland. Now, if you want to trace the whole parasympathetic supply, you need to trace it from facial, and facial gives greater petrosal nerve in the ear, which we are going to talk about later. And then this greater petrosal nerve through the pterygoid canal reaches the pterygopalatine fossa, where it is going to supply the preganglionic fibers to the pterygopalatine ganglion, and postganglionic are going to travel into zygomatic nerve, and then through zygomaticotemporal to lacrimal, and the lacrimal is going to supply the lacrimal gland. Now let's trace this. So this is the facial giving the greater petrosal, reaches the pterygopalatine ganglion. Now from here the zygomatic nerve is going to take it. It is going to connect it with the lacrimal nerve, which is the branch of V1, and then it is going to supply the lacrimal gland. The infraorbital nerve, which was running on the floor of the orbit, it's going to give in the floor of the orbit two branches, the anterior superior alveolar, which is going to supply the anterior teeth, middle superior alveolar, which is going to supply the rest of the teeth besides the molar, and then it would come out as the infraorbital nerve, divide into three branches, nasal, which will supply the side of the nose, the palpebral, which are going to supply the lower eyelid, and labial, which is going to supply the upper lip. So infraorbital, when it comes out, it gives three branches, nasal, which supplies the lateral side of the nose, the labial, which supplies the upper lip, and the palpebral, which is the lower lid, which is going to supply the lower lid. Everybody clear about these branches? Yes.
Doctor, so the ophthalmic nerve, it supplies the front of the nose, right? It
The
does
tip of the nose.
it supply the septum at all, or is it only from
The inner side of the septum, it is not supplying.
That's why the
Yeah.
nasopharyngeal.
Nasopalatine. Mainly.
No,
Yes.
can you explain the posterior, lateral, and
Posterior superior superior lateral or posterior lateral nasal nerves and posterior medial superior nasal nerves. So posterior aspect of lateral aspect of the nose and medial aspect of posterior part of the nose are supplied by the branches of maxilla.
and then the nasopalatine only does the
Septum.
and then it goes to the
Through the inside or to the. We will see it in a minute. We will see all these nerves. So this is the foramen rotundum. From the foramen rotundum, the nerve is reaching in the pterygopalatine fossa, just behind the inferior. This is inferior orbital fissure. So just behind the inferior orbital fissure, you can see the nerve coming from the foramen rotundum. This is after it enters into the orbit, it is going to run on the floor of the orbit, on the groove which is called the infraorbital groove, where it is going to give the anterior superior alveolar and the middle superior alveolar nerves. And then it would exit out from the inferior orbital foramen to give three branches: palpebral, nasal, and labial. If you see here, this is the maxillary nerve entering into the pterygopalatine fossa. You can see this is the pterygopalatine fossa, this is the maxillary nerve coming out. Now it is giving these posterior superior alveolar branches, which are going to pierce the posterior part of the maxilla and supply the upper molar teeth. This is the, once it enters into the groove, it is going to give anterior superior alveolar and the middle superior alveolar branches, which are going to supply the rest of the upper teeth and also maxilla, maxillary air sinus. You can see the lesser palatine and greater palatine are going to supply the hard and soft palate. So these are the branches. This is the nasal branches, the posterior superior lateral nasal and posterior superior medial nasal branches, which are going to supply the posterior aspect of the nasal, but this is the lateral wall, not the medial wall of the nose. And this is the area of supply. Then you have the septum. You see this nasopalatine nerve, which is supplying the septum, and it is going to pass through this incisive foramen to the palate. Here, you can see it here. And this is the zygomatic branch, which is going to divide into zygomaticofacial and zygomaticotemporal, exits out from the side to supply the side of your cheek, and this zygomaticotemporal is going to join the lacrimal nerve. Okay, the third nerve, which we have done quite a bit, so I'm not going to put too much emphasis here because we have done it. We will move to facial more because we need to give time to facial more than this. So mandibular nerve, we know that it is sensory and motor. It is going to supply the lower lip. It is going to supply the lower teeth. Anterior 2/3 of the tongue has general sensations, and it is going to take the taste sensation and join it with chorda tympani to supply for the taste sensation from the anterior 2/3 of the tongue. Muscles which it is going to supply are the muscles of mastication. So besides them, tensor tympani and tensor villi palatini, and some accessory muscles of mastication, mylohyoid, anterior belly of digastric. V3 also carries the proprioceptive information from the muscles of mastication. There are two parasympathetic ganglion attached to branches of it. One is the aortic, attached to the auriculotemporal. One is the submandibular ganglion, which is attached to the lingual nerve. This is the general plan of mandibular nerve, which is quite busy, and I'm not going to go into this. What you are going to see here is this is the main trunk of the mandibular nerve, which is coming out of the foramen ovale. The main trunk is going to give nerve to medial pterygoid, tensor villi palatini, and the tensor tympani. These three nerves are going to come from the main trunk of the mandibular nerve as it comes out from the foramen ovale. Once it happens, it divides into two divisions: anterior division and posterior division. Anterior division is mainly motor, so you can see deep temporal nerves basically supplying the temporalis muscle. Then you have the nerve to lateral pterygoid, and then you have the masseteric nerve, which is supplying the masseter muscle, and the buccal nerve, which is supplying the skin of the buccinator and the mucous membrane inside. Then you have the posterior division, which you see this big nerve. It is going to give the auriculotemporal. You have the lingual going to the tongue. You have the inferior alveolar supplying the lower teeth. And from the inferior alveolar, this is the nerve to mylohyoid, which is supplying the mylohyoid muscle and the anterior belly of digastric. And you can see that the submandibular ganglion is attached to the lingual nerve, and to the auriculotemporal, it would be the aortic ganglion, which is attached. This is the dissection. Yes.
Okay, it doesn't give motor supply to the buccinator, right?
No.
It only gives sensory.
Yes. But sedator is motorly supplied by fissures. Yeah. So here you can see that these are the deep temporal nerves. This is the buccal nerve from the anterior division. You can see from the posterior division the auriculotemporal, the lingual, and the inferior alveolar nerves which are there. If you see this, you can see this is the foramen ovale. Here is the view of the infratemporal fossa, and you can see the foramen ovale here. This is from the top, from the middle cranial fossa, and this is from the infratemporal fossa. You can see the foramen ovale. Here you can see the mandibular nerve coming out. It is giving this buccal nerve here. This is the lingual, and this is the inferior alveolar nerve, and this is the auriculotemporal, which is coming down like this. This is the auriculotemporal nerve. You see here, these are the motor branches of the mandibular nerve. These are the branches to the tensor tympani muscles, the tensor villi palatini and tensor tympani. This is the buccal nerve, as we showed you before. This is the auriculotemporal nerve here. This is the lingual, this is the inferior alveolar. Mostly the dissections which you would see, they would show you the lingual in front and the inferior alveolar behind. This is the most common OSPE sections of the infratemporal, where you would see lingual in front and infratemporal behind. So you can see here, this is the inferior alveolar going into the mandible. This is the nerve to mylohyoid, which is going to supply the mylohyoid muscle and the anterior belly of digastric. This is the lingual nerve, which is supplying the anterior 2/3 of the tongue. This is the cauda tympani joining the lingual. So this is, we are going to talk about in detail the last nerve, which is the big nerve, and you should know this very well. One is, that is called the facial nerve, and know that facial nerve is motor, sensory, and parasympathetic. It is motor to the muscles of facial expression. It is sensory to the anterior 2/3 of the tongue for taste sensation, and some skin around the ear is also supplied by the facial nerve. It is parasympathetic to the lacrimal gland, and it is also parasympathetic to submandibular and sublingual gland. So, lacrimal gland, it is supplying to pterygopalatine ganglion, which is attached to V2. Submandibular and sublingual salivary gland are supplied through the lingual, through submandibular ganglion, through the attachment with the V3 branch of V3, which is lingual. If you have damage to the facial nerve, you have Bell's palsy, which is half side on that side where the nerve is damaged. Usually, viral infections with herpes zoster can cause, facial nerve paralysis, which is Bell's palsy, and you have half side of the face paralyzed, partially lose taste sensations, partially lose salivation or lacrimation in one eye, and may develop hyperacusis. Now we will deal with all of these situations, why it happens. Okay, so facial nerve is basically going to arise from the pons, at the junction of pons and medulla naturally, and it would enter directly into internal acoustic meatus. Internal acoustic meatus will take it into internal ear. Okay, so as it is going to go into the internal ear, it's going to move forward over the cochlea, and it is going to reach the anterior wall of the petrous temporal bone, and then it is going to make a turn. When it is going to turn backwards, it is going to we call it as a genu, because it is turning, so we call it as a genu. This turning back will move the facial nerve to move towards the posterior wall of the middle ear cavity. So it goes straight over the cochlea, reaches the anterior part of the petrous temporal bone, turns backward, move towards the posterior wall of the middle ear cavity, reaches the posterior wall, and then vertically downward to come out from the stylomastoid foramen. In front of the stylomastoid foramen, it finds the parotid gland. So it enters into the parotid gland. and then it divides into its 5 terminal branches, which are temporal, zygomatic, the marginal, mandibular, cervical, these 5 branches which it is going to give on the within the substance of the parotid gland to supply the muscles of facial expression. Now let's see here, this is how it is going to enter. So this is the facial nerve entering into the internal acoustic meatus. This is here, it goes in and it is reaching the petrous temporal bone. This is the petrous temporal bone, and then it is making a turn backwards, which is called the genio. As it is going to make the turn, this is the genio. So you see internal acoustic meatus reaches the anterior part of the petrous temporal bone, turns backward, forming a genio. Now you're seeing inside the middle ear cavity. This is the nerve which is going towards the posterior wall. It reaches the posterior wall, turns downward to exit out from the stylomastoid foramen. So this is how it is basically coming out. And then it is going to, you can see some of the branches which it is giving inside the middle ear cavity. One is the nerve to stapedius, which keeps the stapedius muscle not going into the foot plate of the stapedius not going to vibrate against the oval window. So if this nerve is damaged, so you would have too much vibration to the oval window, that results in hyperacusis. At the time when it is making the genio, here at the petrous temporal bone, when it is making the genio, it gives the greater petrosal nerve. This greater petrosal nerve comes out from the petrous temporal bone in the canal and the foramen of the greater petrosal, finds the foramen lacerum in front, so it enters there, and then it enters into the pterygoid canal to reach the greater petrosal, to reach the pterygopalatine fossa, to the pterygopalatine ganglion. This is the parasympathetic nerve which is taking the parasympathetic fibers to the pterygopalatine ganglion. So it is coming out when it is going to make the genio. In the middle cranial fossa, in the middle ear, it is giving the nerve to stapedius. Just before it exits out from the stylomastoid foramen, it gives a branch which is called the cauda tympani, and it goes back into the ear. So cauda tympani, just before the facial nerve exits out from the stylomastoid foramen, it gives a branch which is like a recurrent branch, goes back into the middle ear cavity, passes on the medial aspect of your eardrum, and exits out from the petrotympanic fissure. This is the petrotympanic fissure, and it enters into the infratemporal fossa. As the cauda tympani goes behind the middle ear, behind the eardrum, passes through the petrotympanic fissure, exits out into infratemporal fossa, where it is going to join the lingual. So the taste sensations are going to go to the cauda tympani. So cauda tympani is arising just before the facial is exiting out from the from the stylomastoid foramen. It goes back into the middle ear, passes on the medial aspect of the eardrum, exits out from petrotympanic fissure into infratemporal fossa, joining the lingual nerve. Then it goes into the parotid gland, where it is going to form a plexus, and it is going to give rise to its 5 branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Now this buccal is different from the buccal of the mandibular nerve. That is sensory. This buccal is motor nerve. Now you can see all of these nerves here, which are basically supplying different parts. You have temporal supplying the frontalis muscle, which is here. You have corrugator superciliary, which is causing for frowning. Orbicularis oculi for closing the eye. Zygomaticus major and minor for smiling. Buccal, you have buccinator, orbicularis oris, levator papillus superioris, levator angularis oris, rhizoras. These are the branches. These muscles are supplied by buccal. Marginal mandibular are supplying these muscles. You can see these tests which we perform to test these muscles and these branches of the nerves. So this is how the facial nerve is going to be tested. You are going to ask the patient to close the eyes, blow, smile, snare. These are the tests which you are going to ask the patient to do because you are testing the facial nerve. So one of the ways which we are going to test the branches of the facial nerve is by asking you some of these tests and then see which.
Doctor, just ask children eyes.
We are not going to go into different very small muscles, the big ones, the orbicularis oris, the orbicularis oculi, so some of the big muscles which you are going to be tested, they are supplied blowing, so these are common tests which we ask patient to do to test the facial nerve. So again, facial nerves pathway is a little bit tricky. So it goes through the internal caustic meatus, reaches the anterior part of the petrous temporal bone, turns from the genu, goes to the posterior wall of the middle ear cavity, turns, comes out to the stylomastoid foramen. At the genu, it is giving greater petrosal nerve, which goes into the nerve and the canal and the groove for greater petrosal to reach the lesser the canal for pterygoid canal, which will take it to the pterygopalatine fossa. In the middle ear cavity, it gives the nerve to stapedius, which supplies the muscle, which is called the stapedius muscle, and that's important for the hyperacusis, issue. And then before it exits out from the stylomastoid foramen, it gives chordal tympani, which goes back into the middle ear, passes on the medial aspect of the middle ear, the eardrum or tympanic membrane, and then it comes out to the petrotympanic fissure into the infratemporal fossa, where it is going to join the lingual. Then once it exits out from stylomastoid foramen, it enters into the parotid, gives its 5 branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. So these are the branches of the facial muscles you already see here, and see the major ones. If you remember, that should be all right. Okay, thank you very much.